Today we will see about errors of refraction. Errors of refraction accommodation. First, let's see about hypermetropy. Hypermetropy or long-sightedness is the refractive state of eye wherein parallel rays of light come from infinity or focused behind the retina with accommodation being at rest. Behind the retina, etiology: hypermetropy may be axial, curvatural, index, positional, and due to absence of crystalline lens. Axial hypermetropy is by far the most commonest form. In this condition, the total refractive power of eye is normal, but there is an axial shortening of eyeball. About 1 mm shortening of anterior posterior diameter of eye result in 3 diopters of hypermetropia. Very important point. Axial hypermetropia may be developmental or pathological. High hypermetropia occurs in microphthalmus, nanophthalmus due to markedly short axial length. Curvatural hypermetropia is a condition in which curvature of cornea, lens or both is flatter than normal, resulting in a decrease in refractive power of eye. About 1 mm increase in radius of curvature result in 6 diopters of hypermetropia. It may be developmental or rarely pathological. Index hypermetropy due to decrease in refractive index of lens in old age due to cortical sclerosis. It may also occur in diabetes under treatment. Positional hypermetropy results from posteriorly placed crystalline lens. Absence of crystalline lens either congenitally or acquired leads to aphakia, condition of hypermetropy. High hypermetropia. Clinical types: simple or developmental or physiological hypermetropy is the commonest form. It results from normal biological variation in development of eyeball. Developmental axial hypermetropia, developmental curvatural hypermetropia. Next is non-physiological hypermetropy results due to either conditions of eyeball which are outside the normal biological variation of development include congenital non-physiological hypermetropia seen in microphthalmus, nanophthalmus, microcornea. Congenital posterior subluxation of lens, congenital aphakia. Acquired non-physiological hypermetropy include senile hypermetropia or frequently designated as acquired hypermetropy occurs in old age due to two causes: index hypermetropy due to acquired cortical sclerosis in old age and curvatural hypermetropia due to decreased curvature of outer lens fibers developing later in life. Positional hypermetropia due to posterior subluxation of lens, aphakia. Congenital or acquired absence of lens. Consecutive hypermetropy due to surgically overcorrected myopia. Acquired axial hypermetropy due to forward displacement of retina as seen in retinal detachment, central serous retinopathy, orbital tumors. Acquired curvature hypermetropia may occur due to post-traumatic or post-inflammatory corneal flattening. Pseudophakic hypermetropia occurs due to implantation of an underpowered intraocular lens. Functional hypermetropia results from paralysis of accommodation as seen in patients with third nerve paralysis and internal ophthalmoplegia. Components of hypermetropia. Nomenclature for various components are follows. Total hypermetropia is the total amount of refractive error which is estimated after complete cycloplegia with atropine. It consists of latent and manifest hypermetropia. Latent implies amount of hypermetropia which is normally corrected by inherent tone of ciliary muscle. The degree of latent hypermetropy is high in children and gradually decrease with age. Latent hypermetropy is disclosed when refraction is carried after abolishing the tone with atropine. Manifest hypermetropy is the remaining portion of total hypermetropy which is not corrected by the ciliary tone. It consists of two components: facultative hypermetropia and absolute hypermetropia. Facultative consists that part which can be corrected by patient's accommodative effort. Absolute is the residual part of manifest hypermetropy which cannot be corrected by patient accommodative efforts. Thus, briefly, total hypermetropy is given by latent plus manifest. Manifest is given by facultative plus congenital or acquired. Age and hypermetropia. At birth, the eyeball is relatively short, having plus 2 plus 3 hypermetropic power. This gradually reduces until by age 5 to 7 years the eye is emmetropic and remains so till the age of 50 years. After this, there is a tendency to develop hypermetropy again, which gradually increases until extreme of life, by which the eye has the same plus 2 plus 3 which it started. This senile hypermetropy is due to changes in crystalline lens changes. Clinical features: symptoms: Asymptomatic, mostly patients are asymptomatic without producing any symptom. Young patient mainly. Asthenotic symptoms at times hypermobility is fully corrected by use of accommodation. Thus, vision is normal, but due to sustained accommodative efforts, patient develop asthenotic symptom. These include tiredness of eye, frontal or frontotemporal headache, watering, mild photophobia, etc. These seasonic symptoms are especially associated with near work and increase towards evening. Defective vision with asthenotic symptoms. When the amount of hypermetropy is such that it is not fully corrected by the voluntary accommodative efforts, then the patient complain of defective vision, which is more far near than distance and is associated with asthenotic symptom due to sustained accommodative efforts. Defective vision only when the amount of hypermetropy is very high and the patient usually do not accommodate, and there occurs marked defective vision for near and distant. Effect of age on vision. Typically, patients with low hypermetropia have good vision in young age. However, with aging due to decrease in accommodative power, the hypermetropia becomes manifest and patient complains of progressive decrease in vision. To begin with, blurring occurs for near vision, then for distant vision also. Size of eyeball appear to be small, and the cornea may be slightly smaller than normal, and is sometimes comparatively shallow. Retinoscopy and autorefractometry reveals hypermetric refractive error. Fundus examination reveals small optic disc which may look more vascular with ill-defined margins and even stimulate papillitis. Retina as a whole may shine due to greater brilliance of light reflection, short silk appearance. A scan ultrasonography biometry may reveal a short anterior posterior length of eyeball in exterior hypermetropia. Grading: low hypermetropia with error is less than or equal to plus 2D. Moderate is plus 2D to plus 5D. High is plus greater than or equal to plus 5D. Complication: recurrent styes, blepharitis, chalacia may occur probably due to infection introduced repeated rubbing of eye, which is often done to get relief from fatigue and tiredness. Accommodative convergent squint may develop in children due to excessive use of accommodation. Amblyopia may develop in some cases. It may be anisometric in unilateral hypermetropia. Strabismus in children developing accommodative squint, or ametropic seen in children with uncorrected bilateral high hypermetropia. Predisposition to develop primary narrow angle glaucoma. The eye in hypermetropes is small with a comparatively shallow anterior chamber due to regular increase in size of lens with increasing age. These eyes become prone to attack of narrow angle glaucoma. This point should be kept in mind while instilling mydriatics in elderly hypermetropes. Treatment is total. The fundamental rules for prescribing glasses in hypermetropia include: total amount of hypermetropia should always be discovered by performing refraction under complete cycloplegia. Spherical correction should be given comfortably acceptable to patient. However, the astigmatism should be fully corrected. Refraction in hypermetropic eye corrected with convex lens. Gradually increase the spherical correction at 6 months interval till the patient accepts manifest hypermetropia. In the presence of accommodative convergent squint, full cycloplegic correction should be given at the first sitting. If there is associated amblyopia, full correction with occlusion therapy should be started. Modes of prescription of convex lens: spectacles are most comfortable. Contact lenses are indicated in unilateral hypermetropia, anisometropia. For cosmetic reason, contact lens should be used. Aphakia literally means absence of lens. However, from optical point of view, it may be considered condition in which lens is absent in the pupillary. Aphakia produces high degree of hypermetropia, causes congenital absence of lens, posterior subluxation of lens. Surgical aphakia, removal of lens is the common presentation. Aphakia due to absorption of lens matter. Traumatic extrusion, posterior dislocation of lens in vitreous causes optical aphakia. Optics of aphakic eye: hypermetropia, high degree, total power of eye is plus 44 to plus 60D. Anterior focal point 23.2 mm in front of cornea, posterior focal point 31 mm behind cornea. Accommodation is lost fully. Symptoms: defective vision. Main symptoms: aphakia is marked defective vision for both far and near vision. Erythropsia, cyanopsia, seeing red and blue images occur due to entry of ultraviolet, low wavelength light. Signs of aphakia: limbal skull, anterior chamber is deeper than normal, iridogenesis, pupil is jet black in color. Purkinje image test shows only 2 images. Normally 4 images are seen. Fundus examination shows hypermetropic small disc retinoscopy and autorefractory reveals high hypermetropic treatment. Spectacles prescription has been the most commonly employed treatment. Presently, use of AFAK spectacles has decreased markedly, roughly about plus 10D with cylindrical lens for surgically induced astigmatism are required to correct AFAK in previously emmetropic patient. An addition of 3 to 4D is required for near vision to compensate loss of accommodation. Disadvantages of spectacles: image is magnified by 30%, so not useful in unilateral aphakia. Problem of spherical and chromatic aberration of thick lenses. Field of vision is limited. Prismatic effect of thick glasses. Roving ring scotoma. Cosmetic blemish, especially in young effects. Contact lens. Advantage of contact lens over spectacular: lens magnification of less magnification of image, elimination of aberration and prismatic effect of thick glasses, wider and better field of vision. Cosmetically acceptable, better for unilateral aphakia. Disadvantages are more costlier, cumbersome to wear, especially in old age and childhood. Corneal complication may be associated. Intraocular lens implantation. Best available method to correct aphakia is intraocular lens implantation. Primary intraocular lens implant is done during cataract surgery. Secondary is done in already aphakic patient. Refractive corneal surgery include keratophakia, epikeratophakia. In keratophakia, a lenticule prepared from donor cornea is placed between lamina of patient cornea, and epikeratophakia, the lenticle prepared from donor cornea stitched over the surface of cornea after removing the epithelium. Hyperopic LASIK may be tried in cases where secondary IOL cannot be implanted. Pseudophakia, condition of aphakia when corrected with intraocular lens implant is referred to as pseudophakia. For types of IOLs, we'll see in further. Refractive status of pseudophakia depends upon the power of IOL implanted as follows. Emmetropy is produced when power of IOL implant is exact. It is the most ideal situation. Such patient need plus glasses for near vision. Consecutive myopia occurs when IOL implanted overcorrects the refraction of eye. Such patient requires glasses to correct the myopia for distant vision, and may or may not need glasses for near vision depending upon the degree of myopia. Consecutive hypermetropy develops when underpowered IOL is implanted. Such patient require plus glasses for distant vision, additional plus 2 plus 3D for near vision. Signs of pseudophakia: surgical scar in the limbus, anti-chamber slightly deeper, mild iridodonosis, tremulousness of iris may be demonstrated. Purkinje image is 4 images. Pupil is blackish in color, but when light is thrown, it reflexes are observed. Presence of IOL is confirmed on slit lamp examination after dilating the pupil. Visual status and refraction may vary depending upon the power of IOL implanted as described above. Management of pseudophakia includes spectacles, LASIK, intraocular lens. Myopia short-sightedness when light rays are focused in front of retina. Etiological classification: axial myopia, the increase in anterior posterior length of eyeball. Curvature myopia, increased curvature of the corneal lens or both. Postural myopia, index myopia, myopia due to excessive accommodation. Grading of myopia: low is this one, moderate is -3 to -60, high is plus the greater than or equal to -60. Congenital varieties: congenital, simple or developmental, pathological, acquired or secondary myopia, which may due to following factors: post-traumatic, post-keratic, drug-induced pseudomyopia, space myopia, night myopia, conjunctive myopia, congenital myopia present since birth, diagnosed by age of 2 to 3, anisometropia, usual present, hence most of the time error is unilateral. High degree of error 8 to 10D. Convergent squint may develop in order to preferentially see clear at its far point. Association may include other congenital anomalies such as cataract, microphthalmos, aniridia, megalocornea, and congenital separation of retina. Early correction of congenital myopia is desirable. Simple myopia, commonest in variety between school-going children 8 to 12 years. School myopia, overall reported prevalence is 20 to 40% of population. It is physiological error. Etiology: it results from normal biological variation in development of eye, which may or may not be genetically determined. Some factors associated with simple myopia are as follows. Axial type of simple myopia signifies just a physiological variation in length of eyeball, or it may be associated with precocious neurological growth during childhood. Curvature type is considered due to underdevelopment of eyeball. Role of diet in early Childhood has also been reported without any conclusive result. Role of genetics. Genetics plays an important role. Parents myopic, then the children will be 10%, and children with no parent is 5%. Theory of excessive near work, watching television, close work. This also causes myopia. Clinical feature: poor vision. Symptoms: poor vision for distance, short-sightedness, astronomic symptoms, half shutting of eyes. If we complained by parents of the children, child has so to achieve greater clarity of stenopic vision. Prominent eyeballs. The myopic eyes typically are large and somewhat prominent. Anterior chamber is slightly deeper than normal. Pupils are somewhat large and a bit sluggish reacting. Fundus is normal. Rarely temporal myopic crescent may be seen. Magnitude of refractive error. It till 18 to 20. It manifests between 5 to 10 years, and it ranges between 18 years, and then till 18 to 20 years it grows. It increases at a rate of minus 0.5 to minus 3.0 every year. Every year. It usually stops during minus 60. Pathological myopia. It is a highly disaster condition, rapidly progressive error which starts in 5 to 10 years. High myopia greater than or equal to minus 60 during early adult life, and is degenerative changes in eye. Etiology: it is unequivocal that pathological myopia results from a rapid axial growth of eyeball which is outside the normal biological variation of development. So far, no satisfying hypothesis has been developed. However, it is definitely linked to hereditary and general growth process. Hereditary, familial, more common in Chinese, Japanese, Arabs, uncommon among Negroes, Nubians, Sudanese, more common in women with men. Autosomal dominant pathological myopia. Role of general growth process, though minor, cannot be named on progress of myopia. Therefore, the factors such as nutrient deficiency, debilitating disease, endocrine disturbance, indifferent general health also occurs. Etiological hypothesis of pathological myopia: genetic factors, more growth of retina, general growth process, stretching of sclera. More growth of retina leads to stretching of sclera, increased axial length, degeneration of choroid, degeneration of retina, degeneration of vitreous. Features of pathological myopia. So, clinical symptom: defective vision, error is usually high, uncorrectable loss of vision may occur, muscae volantis, floating black opacity in front of eye, complained by many patients. These occur due to degenerated liquefied vitreous, night blindness, complained by very high myopes having marked degenerative changes. Signs: prominent eyeball, exophthalmos may be seen in some conditions, cornea is large, anterior chamber deep, pupils are slightly large. Fundus exam reveals following: optic disc appears large, pale, and at its temporal edge characteristic myopic crescent is present. Sometimes peripapillary crescent encircling the disc may be present, where the choroid and retina is distracted away from the disc margin. A supertraction crescent may present on nasal side. Temporal myopic crescent is seen. Degenerative changes in retina and choroid are common in progressive myopia. These are characterized by chorioretinal atrophic patches at macula, Foster Fuchs spot, dark red circular patch due to subretinal neovascularization, choroidal hemorrhage may present at macula. Cystoid degeneration may be seen at periphery. Lattice degeneration or snail track lesions with or without retinal holes, tears may present, which latter may be complicated by retinal detachment. Total retinal atrophy, particularly in central area, may occur in advanced cases. Posterior cephaloma due to ectasia of sclera at posterior pole may be apparent as an excavation with cells bending backward over its margin. Degenerative changes in vitreous include liquefaction, vitreous opacity, posterior vitreous detachment appearing as vis reflex. Fundus change in pathological myopia: Foster Fuchs spot, peripapillary and macular degeneration. Visual fields may show contraction, in some cases ring scotomy may be seen. ERG may reveal subnormal retinogram due to chorioretinal atrophy, retinal detachment, complicated cataract, complications of vitreous hemorrhage, choroidal hemorrhage, strabismus fixus convergence, primary open angle glaucoma, not a complication but is reported association. Treatment: optical treatment. Basic rule of correcting myopia is converse of that hypermetropia. Minimum acceptable to provide maximum vision should be prescribed. It is very high metropia, under correction is always better to avoid problem of near vision. and magnification of images. Modes of describing concave lens are spectacles and contact lens. Contact lenses are justified in case of high myopia as they avoid peripheral distortion and magnification produced by strong concave spectacle lens. Surgical treatment, let's see in future. General measures: balanced diet, early management of debilitating disease. Visual hygiene is very important to avoid asthenotic symptoms. Avoidance of outdoor sports and strenuous activities advised to reduce the risk of ocular trauma and consequent complication of retinal detachment. Low vision aids are indicated in patients with progressive myopia having advanced degenerative changes. Prophylaxis genetic counseling should be given for pathological myopia and school myopia, simple myopia, astigmatism. It is a type of refractive wherein the refraction varies in different media of the eye. Consequently, rays of light entering the eyes cannot converge to a point focus but form focal lines. Regular astigmatism. Regular when refractive power changes uniformly from one meridian to another. Etiology: corneal astigmatism, lenticular astigmatism. Corneal astigmatism is result of abnormality of curvature of lens. Lenticular astigmatism is rare. It may be curvature, positional or index astigmatism. Curvature can be seen as lenticonus, positional seen as subluxation, and index seen as different meridian. Variable refractive index of lens in different meridian. Retinal astigmatism due to oblique placement of macula may also seen occasionally. Types of regular astigmatism: with the rule astigmatism. In this type, the two principal meridians are placed at right angles to one another, but the vertical meridian is more curved than horizontal. Thus, correction of this astigmatism will require the concave cylinder at 180 degree plus or minus 20 degree or convex cylinder lens at 90 degree plus or minus 20 degree. This is called with the rule astigmatism because similar astigmatic condition exists normally. Vertical meridian is normally rendered 0.25d more convex than horizontal meridian, probably the pressure of eyelids. Against the rule astigmatism refers to an astigmatic condition in which horizontal meridian is more curved than the vertical meridian. Therefore, correction of these segments will require the prescription of convex cylindrical lens at 180 degree plus or minus 20 degree, concave lens cylindrical at 90 degree plus or minus 20 degree axis. Oblique astigmatism, a type of regular astigmatism where the two principal meridians are not the horizontal vertical, though these are at right angle at one another. Example: 45 degree and 135 degree. By oblique astigmatism, in this type of regular astigmatism, the two principal meridians are not at right angle to each other. Example: one may be at 30 degree, other at 100 degree. Stumps conoid. At point A, the configuration of rays refracted through a toric surface is called Stumps conoid. The shape of bundle of light rays at different levels at Stumps conoid is as follows. At point A, the vertical V rays are converging more than horizontal H rays, so the section is horizontal oval or oblate ellipse. At point B, vertical rays have come to unfocus while the horizontal rays are still converging, so they form a horizontal line. At point C, the vertical rays are diverging and their divergence is less than convergence of horizontal line, so horizontal oval is formed. At point D, divergence of vertical rays is exactly equal to convergence of horizontal rays, so it forms a correct circle of least diffusion. This is called circle of least diffusion. And at point D, the divergence of vertical rays is more than convergence of horizontal rays. And at point F, the horizontal rays have come to focus while vertical rays are divergent, so a vertical line is formed. Beyond F, both horizontal and vertical rays are diverging, so the section will be always vertical over or prolate ellipse. Focal interval of Sturms reflects to distance between two foci B and F. Refractive types of regular astigmatism: simple astigmatism, wherein rays are focused on retina in one meridian and either in front, simple myopic astigmatism, or behind, simple hypermetric astigmatism. The retina in other medium. Compound astigmatism. In this stage, the rays of light in both meridians are focused either in front or behind the retina and conditions labeled as compound myopic or compound hypermetropic astigmatism. C and D. Mixed astigmatism refers to condition where light rays in one medium focused in front and in other medium meridian behind the retina. Such patients have comparatively less symptoms as circle of least diffusion is formed on the retina. Circle of least diffusion formed here. So A is simple myopic, simple B is simple hypermetropic, C is compound myopic, D is compound hypermetropic, and E is mixed where circle of diffusion is formed on the retina. Clinical symptoms: asthenopia, tiredness of eyes due to difficulty in focusing, blurred vision, dull ache, frontal headache, and sometimes nausea, even drowsiness. Is especially marked in low astigmatism, minus or equal to 1D. Blurred vision and defect vision is important when astigmatism greater than or equal to 1D. Elongation of object proportion to degree and type of astigmatism may be noticed in high astigmatism. Keeping the reading material close to eye may needed to achieve large but blurred retinal image. Signs: half closure of lid, head tilt. Astigmatism may develop a torticollis in an attempt to bring their axis near to horizontal or vertical meridians. Oval or tilted optic disc may be seen on ophthalmoscopy in patients with high degree of astigmatism. Different power in two meridians is revealed in retinoscopy. Investigations: retinoscopy reveals different power in two different keratometry and computerized corneal topography reveal corneal curvature in two different meridian corneal astigmatism. Astigmatic fan test, Jackson cross cylinder test. Treatment: optical treatment, spectacles, contact lens. Spectacle with full correction of cylindrical power and appropriate axis should be used for distant near vision. Contact lens: rigid contact lens may correct up to 2 to 3D of regular astigmatism, while soft contact lens can correct only little astigmatism. For higher degrees of astigmatism, toric contact lenses are needed. In order to maintain the correct axis of toric lens, ballasting or truncation is required. Surgical correction of astigmatism is quite effective. Irregular astigmatism: there are multiple meridians which admit no geometrical analysis. Etiological types: curvatural irregular astigmatism is found in patients with extensive corneal scars or keratoconus. Index irregular astigmatism due to variable refractive index in different part of crystalline lens may occur rarely in patients with cataract. Clinical features: symptoms: defect vision, distortion of object, polyopia. Signs: retinoscopy reveals irregular pupillary reflex. Slit lamp examination may reveal corneal irregularity or keratoconus. Residual disc test, photokeratoscopy, computerized corneal topography. Treatment: optical treatment of irregular astigmatism consists of contact lens which replace the anterior surface of cornea for refraction. Phototherapeutic keratectomy performed with excimer laser may helpful in patients with superficial corneal scar. Surgical treatment is indicated in extensive corneal scarring, consists of penetrating keratoplasty, deep anterior lamellar keratoplasty, DALK. Optical state with equal refraction in two eyes is known as isometropia. Next one is presbyopia. Presbyopia is not an error of vision but a condition of physiological insufficiency of accommodation leading to progressive fall in near vision. Pathophysiology: to understand pathology of presbyopia, working knowledge about accommodation is mandatory. As we know, in an emmetropic eye, far point is infinity and near point varies with age, being about 7 cm at the age of 10 years and 25 cm at the age of 40 years, 33 cm at the age of 45 years. Therefore, at the age of 10 years, amplitude of accommodation A is 100 by 7. Dioptric power need to be see clearly at point is minus 1 by infinity. That is A at age 10, 14 diopters. Similarly, A at 40 years, 10 by 25 minus 1 by infinity is equal to 4 diopters. Since we usually keep the book at about about 25 centimeters, so we can read comfortably up to age 40 years. After the age 40 years, the near point of accommodation recedes beyond the normal reading of our work range. Failing this condition of failing near vision due to age related decrease in amplitude of accommodation or increase in punctum proximum is called presbyopia. Causes decrease in accommodative power of crystalline lens with increasing age, leading to presbyopia occurs due to age related changes in lens. Decrease in elasticity of lens capsule and progressive increase in size and hardness. Age related decline in ciliary muscle power. Cause of premature presbyopia, uncorrected hypermetropia, premature sclerosis of the crystalline lens, general debility causing weakness of ciliary muscle, chronic simple glaucoma, difficulty in near vision. Patient usually complain symptoms are difficulty in reading small prints in dim light or in evening, even in good light. Astronomic symptoms due to fatigue of ciliary muscle. Intermittent diplopia occur due to disturbed relation between accommodation and conversion may experienced by few patients. Optical treatment. 45 years rough guide plus 1 to plus 1.25D, 50 years 1.5 to 1.75D, 55 years plus 2 to plus 2.5D, 60 years plus 2.5 to 3D. Exact presbyopia addition required should however be estimated individually in eye in order to determine how much is necessary to provide a comfortable range. Basic principles are always find out refractive error for distant and first corrected. Find out the presbyopia correction needed in each eye separately and add it to distant correction. Near point should be fixed by taking due to consideration for profession of the patient. The weakest convex lens with which an individual can see clearly at near point should be prescribed. And presbyopic spectacles surgical treatment is also done. Let's quickly see about surgical treatments. Refractive surgery and contact lens. Contact lens is an artificial device whose front surface substitutes the anterior surface of cornea. Therefore, in addition to correction of refractive error, irregularities of the front surface of cornea can also be corrected by contact lenses. Overall diameter of contact lens is linear measurement of great distance across the physical boundaries of lens. It is expressed in millimeters. Bifocal lens, 2-piece cemented supplementary wafer, inserted wafer, fused solid. Contact lens edge, peripheral curve, optic zone, back optic curve radius, optical diameter, overall diameter. Basic curve or central posterior curve. Peripheral curves, these are concentrating to base curve and include intermediate posterior curve, peripheral posterior curve. These are meant to serve as reservoirs of tears and to form a sky for lens movement. Central anterior curve or front curve is the curve of anterior surface of optical zone of lens. Its curvature determines the power of lens. Peripheral anterior curve is a slope on the periphery of anterior surface which goes up to edge. Intermediate anterior curve is fabricated only in high power minus and plus lenses. It lies between CAC and PAC. Edge of lens, power of lens. Measured in terms of posterior vortex power and diameter. Thickness, it usually measured in center of lens and varies depending upon the posterior vortex power of lens. Tint, it is color of lens. Types of contact lenses, 3 types. Hard lens, rigid permeable lens, soft lens. Hard lenses are manufactured by PMMA, polymethyl methacrylate. It has a high optical quality stability and it is durable and cheap, lightweight. Hard corneal lenses have diameter 8.5 to 10 mm. Presently, these are not used commonly. Disadvantage of PMMA or contact lens: practically impermeable to water, thus resistant to tolerance. Being hard, it can cause corneal abrasion. Being hydrophobic in nature, resist wetting, but a stable tear film can be formed over it. PMMA are sparingly used in clinical practice because of poor patient acceptance. Rigid gas permeable lenses are made up of material which are permeable to oxygen. Basically, these are also hard, but somehow due to their O2 permeability they have become popular. Silicon acrylate copolymer of PMMA, cellulose acetate butyrate. Soft lenses are made of hydroxy ethyl methacrylate. These are made about 1 to 2 mm larger than corneal diameter. Advantage being soft and oxygen permeable, the most comfortable, so well tolerated. Disadvantage include problem of wettability, protein deposit getting cracked, limited lifetime, and inability to correct astigmatism more than 2D. Indication of contact lens use. Optical indications. Optical contact lens can be used by every patient having refractive error if so required for cosmetic purpose. Keratoconus, high myopia, inhilatory aphakia. Advantage of contact lens over spectacles. Irregular corneal astigmatism which is not possible to correct lens. Contact lenses provide normal field of vision. Aberrations associated with spectacles. Binocular vision can be retained in high anisometria. Rain and fog do not condense upon contact lens. They do on spectacles. Cosmetically important. Therapeutic indication. Corneal diseases. Non-healing ulcer. Filamentary keratitis. Bullous keratopathy. Disease of iris such as aniridia, coloboma, albinism, glaucoma. For vehicle for drug delivery, amblyopia. Opaque contact lenses are used for occlusion. Advantage of soft contact lenses are used for keratoplasty, microcorneal perfusion. Preventive indications: exposure keratitis, trichiasis. These are diagnostic indications: gonioscopy, electroretinography, examination of fundus in presence of irregular corneal astigmatism, fundus photography, Goldman's 3-mirror examination. Operative indications: goniotomy, vitrectomy, endocular photocoagulation. Cosmetic indication: unsightly corneal scars, ptosis, cosmetic clear lenses, thighs bulby. Include use by sportsmen, pilots, and actors. Occupation: contraindication: mental incompetence, poor motivation, chronic dacrocystitis, chronic blepharitis, recurrent styles, chronic conjunctivitis, dry eye syndromes, corneal dystrophy, recurrent disease like episcleritis, scleritis, iridociclitis, uveitis, etc. Principles of fitting and care of lens. That's also one thing. Let's see about refractive surgery for myopia. Radial keratotomy, laser ablation, corneal procedure, photo refractive keratotomy, keratectomy. Photorefractive keratectomy, myopia seen in front and causing LASIK, laser in situ keratomiliosis. LASIK, tissue flap, laser sculpts the surface, cornea is flattened. Then advancement in LASIK, customized LASIK, femto LASIK. No blade LASIK refers to technique in which corneal fab is made with the help of femtosecond laser rather than microkeratorum. Custom femto LASIK. AP LASIK. Advantages of LASIK: minimal recovery of vision, no risk of perforation. Disadvantage: LASIK is more expensive, and flap related complications include intraoperative flap amputation, wrinkling of flap on reposting, post-operative flap dislocation, subluxation, epithelialization of flap bed interface, irregular astigmatism, other possible complications, dry eye, etc. Relax, refractive lenticular extraction. And the technique is now named SMILE, small instant lenticular extraction. SMILE, anterior side gut lenticular removal. Orthokeratology, lens based procedure, refractive lens exchange, phakic refractive lens, refractive surgery for hyperopia, corneal based procedure, thermal laser keratoplasty, hyperopic PRK, hyperopic LASIK, conductive keratoplasty, lens based procedure, refractive lens exchange, phakic refractive lens, implantable contact lens. Refractive surgery for astigmatic keratotomy, showing flattened deep meridians of cornea, paired transverse incision or flattened steep meridian, showing correction of astigmatism after astigmatic keratotomy. photo astigmatic refractive keratotomy, park LASIK procedure, smile procedure, management of post keratoplasty, astigmatism, selective removal of switches, arcuate relaxing incision combined with compression, corneal wedge resection, LASIK procedure, refractive surgery for presbyopia, monovision LASIK, monovision conductive keratoplasty, presbyopic bifocal LASIK or LASIK palm, presbyopia Avalos Rosakis method, lens based procedure, multifocal or accommodation of IOL, monovision with intraocular lenses, sclera based procedure, anterior ciliary sclerotomy, scleral spacing procedure and scleral ablation, YAG laser or other scleral based procedures still under trial, scleral expansion, etc.